So let's begin. Good evening, Grits. Okay, so I welcome you all to the oral surgery session. We'll be discussing a few more INICET PYQs in this session. And in this session, some questions are simple, straightforward, but some questions have newer or terminologies that you might not have heard of before. So for such questions which are difficult ones, which are tricky ones, I have the explanations or I have small pointers that you need to know. Okay, so let's begin our session. Like I always tell you all, you can answer in the live chat box. You can ask your doubts in the live chat box. Please don't be afraid of putting down your answers. That will give you better confidence and that will prevent future mistakes. Also, whenever you're answering, please also let me know the question number along with your answer. So, coming to the first question, bigonial flaring in symphyseal fracture is managed by A. Buccal reduction, B. Lingual reduction, C. Intermaxillary fixation, and D. Compression plate. So, what would be the answer here to question number 1? Good evening, Shweta. So, what would be the answer here? Okay, more answers. Very good. Others also please answer. I see others have also joined in live. Yes, so the question is asking you about bigonial flaring in symphyseal fracture. So the correct answer here is lingual reduction. Okay, this is the correct answer. Now, please remember, so lingual reduction is the correct answer. Okay. Now, whenever there is a bigonial fracture, whenever there is a symphyseal fracture, it can cause lingual cortical splaying, okay, or separation at the lingual cortex. So you need to reduce. So your aim is to reduce the lingual cortical splay. Alright, lingual cortical reduction is your aim, but please remember no plating is done at the lingual cortex. Plating is only done at the labial cortex. So your plating is done at the labial cortex. Please remember. Coming to the next question, a 20-year-old woman presents to the clinic with 6 months history of pain over the TMJ and reduced mouth opening. On examination, tenderness of TMJ is seen. Radiographic image shows resorptive changes in the condyle. Identify the condition. A is disc displacement with reduction. B is idiopathic condylar resorption. And C is a fractured condyle. And D is TMJ dislocation. What would be the answer over here? Even if you are not sure of the correct answer, please answer. I'll tell you a few points regarding this particular question. try to assess the question, try to see what options might fit in your answer. Okay. Any more answers? Okay. Now let's see. 20-year-old woman presents to clinic with 6-month history of pain over TMJ and reduced mouth opening. On examination, there is tenderness over the TMJ and radiographic image shows resorptive changes in the condyle. Okay, now let us see our options one by one. Now, disc displacement with reduction will always have a click. Okay, but there will be no resorptive changes. The condyle would not be resolved. Okay, there would be no resorptive changes. Okay, idiopathic condylar resorption, you will see condylar resorptive changes. Yes, very good. Ritz cheerleader syndrome. Fractured condyle, there is no history of trauma. The radiograph does not show a fracture, so this is also ruled out. Okay, and TMJ dislocation, the condyle will lie outside the glenoid fossa. Okay, condyle will lie outside the glenoid fossa. Now, idiopathic condylar resorption is our answer. Okay, so we will see a few points regarding this. Prachi, have you understood? Please let me know. Please note down these few points regarding idiopathic condylar resorption. Over the past 3 years, this topic has been repeated twice in INI exams. So there is a major chance that they can ask this again. So let us go through the points one by one. You all can add whatever I am telling you, whatever new points I am telling you, you can add to your study material, either to your notes or from wherever you are preparing. So idiopathic condylar resorption is also known as progressive condylar resorption or condylysis. Alright, it is a condition where the condyle progressively resorbs or it loses its bony content. It is a very rare, aggressive, degenerative disease of the TMJ. It mainly affects young women. So it mainly affects young women. So the male to female ratio, the female to male ratio is 9:1. So it has a very, very strong predilection to affect females. Okay. Mandible retracts and the ramus shortens, which can result in clockwise rotation of lower jaw. So clockwise rotation, that means the lower jaw will tilt in a clockwise direction. Okay. Class 2 malocclusion with open bite. This is very important. Class 2 malocclusion with open bite, and the patient will have a receding chin or a disappearing chin appearance. It is reported in young females, so especially teenagers to adolescent years. This is important. The incidence, the age group is important. It is also referred to as cheerleader syndrome, that is predilection towards female teenagers actively engaged in sporting activities. Okay, these are some very important points. Then there are a few theories. Now, why does idiopathic condylar resorption happen is not clear, is not known, but various authors have, postulated various theories. They have said that these could be the reason why this happens. So the three theories are hormonal mediation, avascular necrosis, and dysfunctional remodeling. What is happening in hormonal mediation is it is more commonly reported among young females in teen to adolescent age groups where metabolic activity due to hormones is predominant. So when the growth spurt is happening, when the pubertal growth spurt is happening, there are fluctuation in level of estrogen and progesterone in the female body. So this could be one of the causes why this phenomenon is taking place, and especially why this is happening in teenagers and as adolescent people. Okay, I'll just try. Okay, Ritz, I'll just check. Now, coming to the next hypothesis, that is, or the next theory is avascular necrosis. So this says that abnormal compression in the retrodiscal area of TMJ leads to capillary constriction, which may lead to idiopathic condylar resorption. So due to cutting off of the blood supply. The third is dysfunctional remodeling, that is inability of the host tissue to remodel and adapt in response to mechanical stresses, which may be the probable cause of idiopathic condylar resorption. Now coming on to the radiographic appearance, it is most commonly, what do you see on radiograph is diminished volume of the condyle and alteration of the condylar contour. Alright, so the condylar contour will be abnormal. It won't be its usual anatomic form. And you can see all of this in OPG, lateral ceph, CBCT, technetium 99 bone scan and MRI. Now what is happening in technetium 99 bone scan? You can see whether the disease process is active or arrested. Okay, whether the resorption is ongoing or it has stopped, because you can only treat after the resorption process has stopped, and MRI is the best modality. Okay, MRI is the best modality. Now the treatment is orthodontics and orthognathic surgery. Orthodontics to counteract the open bite and orthognathic surgery to align the jaws. The second treatment option is condylectomy and reconstruction with costochondral or graft or total joint replacement. And the best treatment actually is total joint replacement. So this is your best treatment. Okay. So let me know if there are any doubts. We move on to the next question. Moderately built athlete with a habit of chewing gum reported to the clinic with complaint of asymptomatic right mandible swelling. On palpation, the swelling is bony, hard in consistency. What would be the diagnosis? A. Traumatic myositis ossificans. B. Parotitis. C. MPDS. And D. Benign masseter hypertrophy. So what would be the answer here? Is the voice issue now fine? Please let me know. More answers, please. Okay, let us look at the question. Moderately built athlete with a habit of chewing gum. Okay, reported to the clinic with complaint of asymptomatic right mandibular swelling. Asymptomatic right mandible swelling. On palpation, the swelling is bony, hard in consistency. What would be the diagnosis? Okay. Now, there is a question which says that there is an athlete who is in a habit of chewing gum. So, what is happening? There is overworking of the masticatory muscles. Alright, the masticatory muscles are continuously in function, continuously under contraction, continuously under stress. Okay, due to which they can undergo hypertrophy. Due to which they can undergo hypertrophy. Alright, so the correct answer here is benign masseter hypertrophy. Okay. Now, traumatic myositis ossificans. For traumatic myositis ossificans, there has to be a history of trauma. Right? There will always be history of trauma or injury to that region. Okay. Parotitis is an acute infection. Parotitis is an acute infection. The patient will have acute systemic conditions like fever, swelling which is tender, overrise, temperature is, overlying temperature is raised, there is associated erythema, alright, all such things will be there in parotitis. And MPDS, again, there would be tenderness in muscles of mastication, there would be spasms of the muscles of mastication, but this particular thing, chewing history, does not correlate it with MPDS. Now, two things that you need to know is masseter hypertrophy and traumatic myositis ossificans. What is the differentiation between these two? So that if future questions come, you can answer accordingly. Alright, so the cause of masseter hypertrophy. The cause of masseter hypertrophy is overworked masseter muscle due to factors like stress, teeth grinding, bruxism, or chewing. Okay. Traumatic myositis ossificans is caused as a response to muscle trauma leading to formation of new benign bone within the muscle. So the symptoms of masseter hypertrophy are enlarged masseter muscles leading to a square jaw appearance, occasional jaw pain and trismus. Alright, so the jaw will become squarish, but pain and trismus can be present occasionally. In traumatic myositis ossificans, there would be a tender, enlarging, soft tissue mass that may also cause pain and trismus. Pain worsens over time. So this would be a progressively enlarging swelling, alright, with pain which worsens over a period of time. Radiographic features in masseter hypertrophy would be, it would show enlarged muscle, alright, enlarged muscle, increase in muscle size. And in traumatic myositis ossificans, you see there is the word ossificans, you will see a presence of a heterotrophic bone which would be growing within the muscle. Alright, so you will see a bone within the muscle. And the treatment for masseter hypertrophy is to decrease stress, ask the patient to, avoid gum chewing and Botox injections to relax the muscle. And in traumatic myositis ossificans, you have to surgically remove the heterotrophic bone which has formed in the muscle, and after which you have to put the patient on physiotherapy. Okay. So the next slide, I have a few visuals. Okay. If you see the first one, this is benign masseter hypertrophy. Okay. I am going to zoom out. If you see, This is your masseter muscle. This is your mandible. Okay, you see that muscle has increased in size, and there is uniform. If you see, there is a uniformity in the radiographic image. It is uniform. All around it is uniform. Similarly here, you see this masseter muscle is bulging more as compared to the normal side. So this is your hypertrophy. Now, if you see traumatic myositis ossificans, there is a heterotrophic bone within the muscle. Alright, there is a heterotrophic bone within the muscle. So I hope these two entities are clear to all of you. I hope it is understood. Deepa, you have understood. Others also, please let me know if you all have understood. Coming on to the next question, the earliest sign of syncope is A. Dilatation of pupil, B. Pallor, C. Constriction of pupil, and D. Bradycardia. So what would be the answer here? Please come on everyone in the live chat. I need your answers. Whether the question is easy or difficult, please attempt. This is not your exam. And please mention the question number along with your answer. Very good, Deepa. Others, please answer. So the earliest sign of syncope is pallor. Okay, I have a few points regarding syncope as well. But before that, we'll go on to the next question. Coming to question number 5. A patient in dental chair suddenly becomes unconscious but is breathing. What should be the next step? A is check BP and intubate. B is 12 lead ECG. C is CPR immediately. D is recline the chair, shout for help and give oxygen. Please let me know the answer. Very good. Others also please answer. Whosoever is watching. Whosoever is watching, please answer. Now let's understand. So there is a patient in dental chair who suddenly becomes unconscious. Okay, but is breathing. Okay, what is breathing? So your airway ABC. Alright, airway is fine. That's why the patient is able to breathe. Just the patient is unconscious. The most common cause of unconsciousness in a dental operatory is syncope. Now, what is syncope? Syncope occurs due to cerebral ischemia. I'll also tell you the pathophysiology of syncope. Due to reduced blood flow to the cerebral tissues, there can be cerebral hypoxia. So the first thing, if the patient is unconscious, you will try to establish responsiveness and then you will administer oxygen so that the oxygen perfusion to the cerebral tissue increases and patient can regain consciousness. Okay. So you do a 12 lead ECG if you are suspecting a asystole or a cardiac arrest. First you have to administer oxygen. Okay. CPR again, if the patient is pulseless, is not breathing, is completely unresponsive, you will administer or you will start CPR. And you will intubate the patient only if the patient's GCS is less than 8, patient is completely unresponsive and you cannot establish A, B or C. Okay. So here, recline the chair, shout for help and give oxygen. This is the correct answer here. Now let's see a few points about syncope. You all can add this into your notes. Okay. So these are, I've picked this from the Malamed Handbook of Medical Emergencies in the dental office. So first of all, let's see what are the predisposing factors for syncope. So they include fright, anxiety, emotional stress. These are the psychogenic factors, all right, which due to the psychogenic or psychological status of the patient, these factors come into play. So it can be fright, it can be anxiety, emotional stress, receipt of unwelcome news, pain, especially sudden and unexpected, which happens in a dental office. Non-psychogenic factors include erect sitting or standing postures, hunger from dieting or a missed meal, exhaustion, poor physical conditions, hot, humid, crowded environment, male gender and age between 16 to 35 years. Okay, so these are the predisposing factors for a syncope. Now let's see what are the signs and symptoms. So in syncope we have early signs and symptoms and late signs and symptoms. In early we have feeling of warmth. The patient will suddenly start feeling warm. Loss of color, pale or ashen grey skin tone. Hyperperspiration, that is a lot of sweating. Reports of feeling bad or feeling faint. Nausea, blood pressure at baseline level or slightly lower. So decrease in blood pressure and tachycardia, that is increase in heart rate. The late reactions or the late signs and symptoms are pupillary dilatation, yawning, hypernia, cold hands and feet, those are cold extremities, hypotension, bradycardia, visual disturbances, dizziness. Visual disturbances can include blurry vision, diplopia, okay, dizziness and loss of consciousness. So the earlier signs, what our question was saying, loss of color, that is nothing but pallor, loss of color. So it is one of the earliest signs and symptoms of a syncope. Now I have mentioned the pathophysiology of syncope. So how does a syncope take place? What is the whole mechanism why a syncope is happening? So if there is a stressful or a fearful environment, let's say a dental clinic, so there are increased catecholamines that are released into the circulation. Now catecholamines are increased as a response to fight and flight response. Okay, so if there are catecholamines released, okay, and the flight and fight response is activated, so if the patient jumps out of the dental chair and runs away, that means the increased catecholamines are utilized, and because the patient has run away, there is muscular action that has taken place. The patient has run away, so nothing will happen to the patient. But now what is happening if there is a patient on the dental chair who is under stress, under fear, there is increased catecholamine release. So what will happen? Peripheral vascular resistance will decrease. Okay. Now when peripheral vascular resistance decreases, there is increased blood flow to the periphery region, or the periphery skeletal muscles, they have increased blood flow. Okay. So there is peripheral pooling of blood. So pooling of blood in the legs. To say it very simply, pooling of blood in the legs. Now what will happen if there is pooling of blood in the legs? There will be decreased blood volume which will return to the heart. Okay. If there is decreased blood volume which will return to the heart, there will be decreased cardiac output. And if there is decreased cardiac output, that means there is decreased arterial blood pressure. And decreased arterial blood pressure will in turn cause less blood flow to the cerebral tissues, which will cause hypoxia and which will cause syncope. Okay, so this is the pathophysiology. So if the patient is under stress, sitting on a dental chair for a long period of time, will, due to all these mechanisms, will have a syncope. But if a person who is sitting on the dental chair, he activates his flight and fight response, the patient will be absolutely fine. Okay. Now coming to the management of this particular condition. So let me zoom out. You assess the condition. You see if the patient is responsive or not. You assess whether the patient is conscious or not. Okay. Now you activate. If you establish unconsciousness, you make the patient lie down in a supine position with the feet slightly elevated. Now what will the elevated feet do? It will increase the return to the heart. Okay. You assess previously it was CAB, now it is ABC. You assess airway, breathing and circulation. Okay. And you see if the patient is breathing or not, if the airway is patent or not. If these two things are present, you have to administer oxygen. Administer oxygen. Monitor vitals. Okay, heart rate, pulse rate, blood pressure, oxygen saturation. You have to do this. Perform additional procedures like administer aromatic ammonia. That is a respiratory stimulant. Okay. You can give patient sugar, orange juice, a soft drink, and administer atropine if bradycardia persists. Most importantly, do not panic. If the patient has recovered, if the patient has recovered, then you postpone further dental treatment. If there is delayed recovery, you activate the medical emergency services. In USA it is 911, for us it is 112. Okay, and you retrospect what are the precipitating factors, what causes the syncope, whether it is due to some systemic condition or whether it is psychogenic or whether the patient did not have a meal. So you have to identify and take the corrective measure in the next appointment. Okay. So that was all about syncope. Please make a point of all these notes that I gave you so that these things are easier to understand and answer in your exam. Coming on to the next question. For extraction of mandibular third molar, LA was injected in a diabetic patient. After injection of LA, he complains of double vision. What can be the cause? A. Hyperglycemia, B. Hypoglycemia, C. Syncope, and D. Inadvertent injection into the infraorbital foramen. So what would be the answer? Please let me know, everyone, in the comment section. Yes. So yeah, Ritz, I'll answer your question. MRI is helpful in a way that it rules out any disc related abnormalities. It tells you that the disc is okay, but the issue is in the condyle. Okay. Whenever there is a TMJ related issue, you always have to make sure, you always have to pinpoint where the exact cause of the disease process is. So MRI, CT, OPG will just tell you the hard tissue. MRI tells the soft tissue better, but it also tells us about the hard tissue. So it will tell you whether there is a discal issue or there is actually problem with the condyle. Okay, I hope that answers your doubt. Okay, more question. This question is framed by the examiner so that you all do mistakes. So let me know. What would be the answer here? Please try and answer this one question. At least I want everyone to answer, even you do not know what is the correct answer. Others also please answer. Okay, let's see at this question. Extraction of mandibular third molar. LA was injected in a diabetic patient. Okay. After LA, he complains of double vision. What would be the cause? Okay. Now, when you are extracting a mandibular third molar, you will give inferior alveolar nerve block. You will give lingual nerve block and long buccal nerve block. Okay. There is no way the LA can go into infraorbital foramen. For a third molar, you will not give any maxillary, mandibular third molar, you will not give any maxillary nerve block. Okay, so this is ruled out. Now we have hyperglycemia, hypoglycemia and syncope. Now in hyperglycemia, the patient is fatigued, extremely thirsty, like dying for water, extremely frequent urination and fruity breath due to accumulation of ketone bodies, diabetic ketoacidosis. Okay, so even hyperglycemia we have ruled out. Now the confusion remains between option B and C, hypoglycemia or syncope. Now since it can be double vision, can be due to syncope, but in a diabetic patient, the hypoglycemia will be the cause of syncope. So a hypoglycemic event will lead to a syncope. So the better answer here is hypoglycemia, since the question has mentioned a diabetic patient. Okay, if the question does not mention a diabetic patient, you can go with syncope as your answer. All right, is this understood? Everyone? Deepa, have you understood? Please, this is very important. Note down what I've told you. Coming to the next question, question number 7. Oxygen supply is needed for patient admitted in ICU. Okay, there's some issue with the numbering of the questions. I'm sorry, but answer according to the display on the screen. Okay. Oxygen supply is needed for patient admitted in ICU. According to color coding, how will one identify the oxygen cylinder? A, blue cylinder with white collar. B, black cylinder with white collar. C, white cylinder with black collar. And D, white cylinder. So what would be the answer over here? Very good, Deepa. Others, please answer. So, a oxygen cylinder is always black cylinder with white color. Okay. This is how a oxygen cylinder is identified in the hospital. Fine. Now, just have a look at these these three cylinders. Sorry. So, a oxygen cylinder is black body with white collar or white shoulders. Okay. Nitrous oxide is a blue cylinder and nitrogen is a black cylinder. Okay. Please remember this. This is very important. Coming to question number 8. Medial displacement of condylar head during subcondylar fracture is due to action of which muscle? A. Medial pterygoid, B. Lateral pterygoid, C. buccinator, D. masseter. Very simple question. I want all of you to answer. Very simple question. Come on, everyone. Yes, very good. More answers. Lateral pterygoid is the correct answer. Question number 9, another easy question. After gap arthroplasty, which of the following steps will be necessary for functional rehabilitation of condyle? A. Physical therapy. B. Interpositional fat fascia. C. Costochondral graft. Or D. Reconstruction plate. What would be the correct answer here? Very simple question. We have discussed this before also in our MCQ sessions. Yes, others also please answer. What would be the answer here? So the correct answer is physical therapy. Can anyone tell me why do we do physical therapy? What is the idea behind physical therapy? Short answer. Why is physical therapy done? Anyone can tell me? Very good, Deepa. Very good, Ritz. Can anyone tell me why do we do physical therapy after surgery for TMJ ankylosis? So this is to prevent Rianka. Very good. Yes. Yes. To prevent reankylosis. Also to get back the patient in function. This is also correct, Deepa, but this is partly correct. But our ultimate goal is to prevent reankylosis. Alright. To exercise, to restore function. Yes, that is also one of the goals, but that is not our main aim. The main aim is to prevent reankylosis. Okay. Coming to question number 10, which is the most commonest site for costochondral grafts? A. 4th rib, B. 6th rib, C. 8th rib, and D. 11th rib. Again, very simple, straightforward question. It's mentioned in my notes also. Please answer. Please answer all these questions. I'm waiting for your answers. Very good. Others also please answer. Which is the most commonest site for costochondral graft? The answer is 6th rib. Alright, the answer is 6th rib. Let us see. Now, 5th, 6th and 7th rib. 5th, 6th and 7th rib. Okay. 5th and 6th we use in male patients and 6th and 7th we use in female patients. Okay. Use the 6th and 7th rib in female patients to hide the scar in inframammary crease. Okay. So, this is the common one. Alright. For males and females, we can use 6th rib, both in males and females. That's why 6th rib is the answer. Have you understood, Deepa? Is it clear? Okay. What is explained in this image? So I will draw an arrow. I forgot to place an arrow. I have placed an arrow. What is explained in this image? A. Dynamic compression plates. B. 3D plates. C. Champy's mini plates. And D. Bone grafting. Please answer as per the red arrow. The arrow that has been marked. I can also zoom out the picture for you all. Dynamic compression plates, 3D plates, Champy's mini plates or bone grafting. Think and answer. See the image, study the image for 2 minutes. See what is being given in the image. Deepa, see the image again. See the arrow again. Let's look at the image carefully. See how the image is. Okay, so the correct answer here is a 3D plate. It's a 3D plate. Now, 3D plates are basically nothing but geometric plates. Okay? Geometric plates. Fine. Now, geometric plates can be like this. It can be a square. Okay. It can be a rectangle. It can be a it can be a cross, it can be a triangle, okay. It can be Y-shaped, okay, and in rectangular also it can be of various sizes and shapes, okay. So these are 3D plates. These are known as 3D plates or geometric plates. Just a few points about 3D plates. Okay. What are the advantages? You don't need to go into details. Okay, this is a postgraduate level thing, but just know a few points. Okay, the advantages and disadvantages, they are most important. So, enhanced stability, superior stability against powerful torsional and bending forces exerted by masticatory muscles. So they give better stability in comparison to mini plates. They are type of mini plates only. All right, please remember these are type of mini plates only, but these are the 3D plates. Okay, reduced operating time. Reduced operating time, easier plate adaptation, less hardware failure rates, reduced complications, improved patient outcomes, that is, patient experience faster functional recovery. That means patient can get back to function faster. These are the advantages. Okay, they don't loosen easily, they reduce the operating time, they get back the patient to function faster, they can withstand torsional forces as a result of mastication. Okay. Now the disadvantages are technical demands. So this is complex plate geometry, right? Because they are in different sizes, different forms, they are complex in geometry. So you have to be technically sound to use them. They cause risk of nerve damage. Now what is happening in two mini plates? You can, adjust if there is a single plate, you can adjust that according to the nerve, if there is any nerve which is coming in your field. But a 3D plate has a preform, so you cannot adjust it because it is more bulkier, it is bigger in size, it is expensive, and there is excessive implant material. Okay, because there are crossbars in the 3D plate, so it has excessive implant material. That is all that you need to know about 3D plates. Coming to question number 12. Treatment for the given cleft is ideally done at A 6 months, B 9 months, C 18 months, D 12 months. What would be the answer here? Question number 12. Please answer. Please answer. All of you. Answers, please. Yes, on the other side, Ritz, there were two mini plates. We will just go back. Yes, these are the two mini plates. Alright, these are the two mini plates. Okay. The others were two mini plates. They were not connected. These, if you see, I'm going to zoom out. You can see they are connected. Okay, Ritz? Answer to question number 12. Okay. So for a cleft palate, the ideal is 9 to 18 months. Okay, but if you have to choose any, if both of them are given in the option, 9 is also given and 18 is also given, the best thing that you will choose is the middle one, 12 months, because you have to do a cleft palate repair before speech development. Okay, so the best is out of 9 and 18, the middle range, that is 12 months or before the patient turns 1 year, or at the time when the patient is turning 1, for better speech development. So 12 months is the correct answer. Some books also say that you can do a cleft lip repair at 6 months, but at 6 months tissues are very fragile, suturing is difficult, handling the tissues is very difficult. The best time to do a cleft repair, cleft palate I'm talking about, cleft palate only. Cleft palate is between 9 to 18 months, and the amongst both is also the best is 12 months if it is given in the option. If 12 months is not given in the option, you will mark 9 months. The earlier the repair is done, the better it is for the patient's development of speech. Okay, I hope this is clear to all of you. Very important points I've told. Okay, we are left with last 2 questions for this session. Very simple, straightforward questions told in my class also many times. So please answer. The wall which most commonly collapses in orbital blowout fracture is medial, A medial, B lateral, C roof, D floor. So what would be the correct answer here? Okay, anyone else who wants to answer? So yes, the correct answer is D. Okay. Most common to fracture is floor, weakest wall is medial. Please remember, I've told this many times in my class, in my notes, everywhere it is mentioned, in my previous sessions as well. Please remember, the most common to fracture is the floor and the weakest wall of orbit is the medial wall. Coming to the last question for today. Facial bone which is more prone to fracture is A. Nasal, B. Mandible, C. Maxilla, D. Zygoma. Again, I have told this before. It's there in my notes also. What would be the answer here? Yes, more answers please before we wind up the session. Any more answers? So the facial bone which is more prone to fracture or more commonly fractured is nasal. Okay, if nasal is not given in your options, the next that you will mark is mandible. Okay, If nasal is not given in our options, the next best to mark is mandible. Okay, please remember this. Okay. And this question, there is another way of framing this question. Which facial bone offers least resistance to fracture? Alright, or the facial bone which offers the least resistance to a traumatic force. This question can be asked in multiple ways. Alright, so please keep these things in mind. So that was the last question for today. Okay. Here is the schedule for the upcoming week, for the next few days. Please note this schedule down. Okay. Rest, all I want to tell you all is you all are doing well. My advice to you would be, don't be afraid of your INI paper. Attempt it with confidence. Read the questions carefully. Try to see what the question is pointing towards, what the options are, what is correlating with what is being asked in the questions. Most of the times, even if there comes a question which you have not heard of before, do not do a random guess. Attempt it carefully. Try to see if you can arrive at the answer. Alright, if you cannot, if you have no idea, it is best to leave such questions. There is no point in gaining negative marks because that's not our goal. In a scenario where you think that you do not know anything, try to at least read the question carefully. Most of the times your clues are present in your questions. Okay. I will update, Ritz will update the schedule. As of now, this is the schedule for the next week, after which we'll update the schedule on YouTube. Okay, so you can come and see when is the next class. You can keep visiting the YouTube page. Okay, you will, our sessions are scheduled, pre-scheduled, so you can go to the live section on YouTube and see what classes are scheduled for after 25th. Okay, that will be available to you beforehand. Are there any doubts, students? Anyone wants to ask any question? Let me know. I'll wait for 2 minutes. Thank you for joining in, students.